Greetings for all the Selnet community, and I'm very welcome to this CTOS meeting. I think this meeting gives the consortium more visibility, and I think it's very appropriate to have this kind of meetings. So first of all, congratulations for the recent acceptance of Selnet soft tissue sarcoma and GIST clinical practice guidelines, thanks to the Lyon team, especially Jean-Yves and Julien Boyard. So the bone tumor guidelines will be sent by the end of this week. So it's a very nice and very good news. And the cancer treatment reviews is the journal. So it's very nice. So CTOS context, I think, is a great opportunity to join a Selnet consortium, and hopefully the next edition will be inside in Vancouver as well. So we will have the opportunity to join and to make business and to celebrate the reencuentro, no sé cómo se dice en reencuentro in English, to celebrate see us again. Yeah. So we have for today's session a luxury team, and so after every lecture we will have time for interactions, for questions, and so Nadia will present the first speaker.
Yeah, so good night, everybody. Good afternoon in America. It's my pleasure to introduce our first speaker. Is William Tapp, the chief of the Sarcoma Medical Oncology Service of the Memorial Sloan Kettering Cancer Center in New York. And he will discuss in the next minutes about the updates in the soft tissue sarcomas, focusing in the common subtypes. So Bill, thank you very much for joining us. It's your time.
So first, Nadia, please mute your microphones if you are not talking. And in the meanwhile, you can launch questions in the chat during the presentation. So please mute your microphones.
So can you see my screen? I'm just going to see if I can get it to the right screen. Can you see that?
Yeah.
Okay, perfect. Well, thank you very much for having me here to talk, and today giving a presentation on updates in soft tissue sarcoma. Whoop, that's not what I wanted to do. Giving you an update on some of the more common subtypes and what's been happening. And so what I'd like to do as I get my screen set up is to focus a little bit on some of the more common subtypes, and specifically spending some time on GIST because there's been a lot of movement, Liposarcoma, in which there's been some nice advancements coming out, and then trying to bridge that into some of the things that we're learning about immunotherapy, specifically as we think about some of the more common subtypes, and if time, talk a little bit about PARP inhibitors and Lyomyosarcoma. So I think when we focus on GIST, what we're trying now to do is really understand the diversity of this disease that happens in people after they've had multiple tyrosine kinase inhibitors. And I think we all know that polyclonal resistance develops. Whether or not it's the selection for this resistance or an emergence of the resistance is still being debated, but how we as clinicians can now target this becomes critical. Why is this critical? Because we've seen now the emergence of drugs that claim really to target a wide spectrum of resistant mutations. One of those drugs is ripretinib, which is a switch pocket kinase inhibitor, which can actually sit in the switch pocket to prevent the activation of the kinase. And so we now know of the Invictus study, which was a phase 3 study randomizing patients in the 3rd and 4th line setting to get either ripretinib or placebo, and there was a crossover. And this led to FDA approval based on these data. Overall response rate was about 9.4%, which is generally what we see, but the progression-free survival in heavily pretreated patients was 6.2 months, months, which was very reasonable. Importantly, you see how placebo did with a median progression-free survival of 1 month. So we really question now, the utility of placebo-controlled studies. Are we hurting patients who are on placebo when they're heavily pretreated? If you look at the overall survival data, knowing that there was a crossover, we weren't able to really salvage a lot of patients, right? So were we hurting patients? And you have to weigh this with getting a drug approved, right? So are placebo-controlled studies something that we will continue to do in GIST? Also importantly, coming out from these trials, which are very important, is the understanding of the circulating tumor DNA and its application in GIST. This is critical so we can actually learn what types of mutations were on the study and actually how well the drug worked in these mutations, and comparing this then to our preclinical assumptions, right? This is critical, but early data, but very important to actually see these data come out from the clinical trials. Right around the same time that ripretinib came out, avapritinib came out. Now, avapritinib is another multi-targeted tyrosine kinase inhibitor that was thought again to hit a broad spectrum of mutations, specifically exon 17, 18, but later on, the company came out with some data suggesting that it also worked well in exon 13, 14 mutations, as you can see in the diagram down here in the right. So very hopeful for this drug as well. Importantly, as the drug was going through its clinical trial development, there were some very nice signals in PDGFR alpha D842V mutant GISTs, a disease that we tended not to have good treatments for because they did not respond to drugs like imatinib. And you can see in the extension cohort of patients with D842V mutations, you saw dramatic responses, beautiful waterfall plot that actually led to the approval of avapritinib in the United States, specifically in D842V mutated GIST. Avapritinib took a different approach than ripretinib in that they decided to come in an earlier line clinical trial. And so to do that, they actually positioned themselves against regorafenib after receiving treatment with imatinib and sunitinib. And this was a critical trial and one of the first comparators against an active agent in our community. But unfortunately, this was a negative trial. And what you can see here is that the PFS actually may have favored regorafenib slightly over avapritinib, right? And so there were a lot of preclinical assumptions that regorafenib was not a well-tolerated drug and or avapritinib could target a broader mutational spectrum, but clearly here the data shows equivalence. And what was also noted with this trial was that we started to see some atypical side effects with avapritinib, such as cognitive disorders that could have also affected its clinical use. So not only maybe did our community learn how to use regorafenib over time to make sure that we could maintain dose integrity, but also we may have overinterpreted how well targeted a drug like avapritinib is. But a very important study because it helps give us ideas about how to design clinical trials in GIST. Right around the time that the avapritinib study was actually, the data was emerging, the INTRIGUE study, which was a phase 3 study of ripretinib, was accruing. So the INTRIGUE study was actually looking at ripretinib versus sunitinib in the second line study. So now our second trial in GIST actually comparing a new drug to active comparator, excuse me. And so this was ripretinib at 150 a day versus sunitinib at some of the earlier dosing schedules we used at 50 milligrams per day, at least for the initial cycles. And unfortunately, we just heard last week through a press release from Decipher that this too was a negative trial. So our second trial against an active comparator was negative. So PFS was 8.3 months for ripretinib compared to 7 months for the sunitinib arm. So very unfortunate for our community because there was a lot of interest in using ripretinib in different lines of therapy. But one of the things that we really have to struggle with is why were these trials negative? Did we not predict for the clinical heterogeneity or stratify correctly on these clinical trials? Maybe we also overinterpreted some of the in vitro and in vivo data, thinking that the newer drugs targeted a larger spectrum of actually mutations than they were able to target clinically. Like I mentioned before, there could also be some questions that we overinterpreted the toxicity of some of our drugs, or our community has learned how to use these drugs over time. And things that we don't often talk about are what are the other types of resistance that develop. We know some GISTs have loss of P16 or other areas that could confer resistance to some of the tyrosine kinase inhibitors as well. Something we've learned from Olaratumab, we may not be studying in phase 3 populations the same patient population that we're studying on early phase 1 and 2 clinical trials. So how can we keep these populations consistent throughout the development strata of a drug? And is there any variations as we move from smaller studies into larger international studies? So these are critical questions that our community really needs to tackle, because these again are the first comparator studies of significance in GIST, and both were negative trials. There are other studies that are probably going to emerge now. There's a lot of interest in the Plexicon 9486 drug recently bought by Cogent in combination with sunitinib, possibly understanding to see if it can actually overcome a broader spectrum of mutations. Early, again, phase 1-2 clinical trial data suggested activity of the combination with median progression-free survival of about 10 months. Again, we have to be careful in interpreting smaller phase 1 data as we start to think about expanding into larger phase 3 clinical trials. And can we learn anything from the recent negative studies as our community begins to develop ways to bring in novel combinations? We also have a lot of interest in questioning if there's anything that can be done in the earlier setting, meaning the upfront or the first line setting. We have interest in targeting ETV1, which is now known to be a master regulator in GIST. So KIT signaling can actually activate ETV1 through MAP kinase signaling. ETV1 activity in a feed-forward loop can then stabilize KIT signaling. What's important is there's been some really nice preclinical data to suggest that if you can target the MAP kinase pathway, you can shut down ETV signaling. For us, this led to a phase 1b/2 study of a MEK inhibitor, binimetinib with imatinib in patients with newly diagnosed GIST. The MEK inhibitor alone probably does not have activity, and you do need an active tyrosine kinase. So that's one of the reasons we went into the first line therapy. Ping Chi presented this data at ASCO last year. So in a cohort of about 40 patients, there was about a 70% response rate. And the median progression-free survival was about 30 months. So, impressive when we compare it to historical controls, but again, very difficult to do, and take this with caution when we think about smaller single institution phase 2 data sets. But the question then becomes, how can we look at potential novel combinations earlier on in the treatment with GIST to really see if we can improve outcomes in this patient population? Another potentially hard clinical trial to develop. But all of this becomes important because we're on the verge of the next generation of tyrosine kinase inhibitors coming out. This is actually an AZD compound recently bought by Nube. And when you look at the mutational spectrum, again, at least in vitro and in vivo, it seems to be very broad in its activity. Another drug by Theseus is coming out as well into early clinical trials. So very important for our community to understand how to develop these correctly, how to interpret preclinical data, how to select patients, how to actually mirror those patient populations over time, and then potentially even to use and apply circulating tumor DNA in the development of these clinical trials. So from there, talking about GIST, I'd like to focus on another prevalent soft tissue sarcoma, liposarcoma as a group. Really 3 different types: the well-differentiated, dedifferentiated liposarcoma, known to have copy number alterations, very specifically almost always having gains in the long arm of chromosome 12 with 2 amplicons, one centered about CDK4, one around Mdm2, both thought to be important in the pathogenesis and propagation of this disease. And then also myxoid round cell liposarcoma, which is a translocation positive sarcoma characterized by a fused CHOP translocation, and then pleomorphic sarcoma tending to be a little bit more like undifferentiated pleomorphic sarcoma, having abnormalities in P53 and RB. But when we look at the recent history of liposarcoma, we definitely have to talk about the 2 clinical trials where we saw the approval of trabectedin and eribulin. Both came out at the same time, both very similar patient populations and design. This is the trabectedin versus dacarbazine in the L sarcomas. This trial had a benefit of trabectedin over dacarbazine for progression-free survival, but not overall survival. It was a highly censored study, so we have to interpret the overall data with some caution. The devils, though, are in the details when we look at the subset analysis, specifically an active drug in Lyomyosarcoma compared to dacarbazine. But when we look specifically at liposarcoma, seems to preferentially have activity in the myxoid round cell liposarcoma, but didn't seem to be better in dedifferentiated or pleomorphic liposarcomas. This drug, however, in the United States did get approval for both leiomyosarcoma and all types of liposarcoma. When we contrast this to the eribulin study, there was no improvement in progression-free survival, but a few-month improvement in overall survival. Again, the devils are in the detail here. This drug did not seem to have a benefit over dacarbazine in leiomyosarcoma, so not FDA approved for that indication in the United States, but really did seem to have activity in the different liposarcoma subtypes, although some of them were smaller numbers, but having activity in dedifferentiated liposarcoma and myxoid round cell liposarcoma. So for liposarcoma, both of these drugs can really help our patients when used in the appropriate setting. Importantly, when we specifically talk about myxoid round cell liposarcoma, translocation positive sarcoma like synovial sarcoma, they express testes-specific antigens, MAGE as well as NY-ESO-1. And because of that, they've been really good diseases to study the application of adoptive T-cell therapies that have been engineered against the testes-specific antigens. This is data from Sandra D'Angelo and also Brian Van Thyme looking at targeting MAGE-4 in synovial sarcoma and myxoid round cell liposarcoma. And specifically, when you look at myxoid round cell liposarcoma, you see about a 25% response rate, and responses are durable. Important early data, but it's really been the foray for these treatments into solid tumors where our community has helped understand the appropriate application, the appropriate preparative cytotoxic regimens that are required, and also what is the right timing in patients to actually begin to use these therapies. But we'll be seeing this emerging more and more in the treatments of our patients. Palbociclib for liposarcoma, CDK4 inhibitors have now been well studied. These are two studies by Mark Dixon looking at different doses and schedules of palbociclib. What I actually did was I combined the data sets looking at median progression-free survival. And what you can actually see are that there's a subset of patients that really don't respond to respond to therapy. There's about a third of the patients, this red circle here, that have meaningful responses when we compare it to EORTC benchmarks. And then there's about a third of patients that have dramatic responses. And these patients were all progressing on trial. So CDK4 inhibitors can be very good treatments for patients with dedifferentiated liposarcoma. Mark also recently worked on abemaciclib, which is a continual dosed drug in patients with liposarcoma. In a small cohort of patients on a phase 2 study, the outcome seemed to be a little bit better than palbociclib. Median progression-free survival was about 30 weeks in patients who progressed onto study. We don't know if this improvement will actually hold out in larger data sets. And if we do see that, whether or not that also includes continual quiescence of a drug dosed continually versus also the conversion into senescence, which may be the more meaningful outcome in patients with liposarcoma. But why important? There is a phase 3 study versus placebo of abemaciclib in dedifferentiated liposarcoma that is actually going to be run through SARC. And I think that trial is just about to start up. Importantly, correlative experiments from this trials have been very important in understanding what happens with cell cycle arrest after exposure to a CDK4 inhibitor. What we now know based on some of the work from Amy Crago and Andy Koff's lab is that almost all cells upon exposure to a CDK4 inhibitor actually exit the cell cycle and undergo or enter into the state of quiescence, which is a reversible form of cell cycle arrest. There's a subset of those cells that actually progress through geroconversion into senescence. And what we now know is that the downregulation of MDM2 is critical to this process. This happens in a p53 independent manner. You get dissociation of HAUSP, which is a deubiquitinating protein, and MDM2 gets ubiquitinated. And we can actually see that in some of the extreme responders in our palbociclib studies. But it also highlights the importance of MDM2 in the pathogenesis and propagation of dedifferentiated liposarcoma. And we actually feel that it's probably the stronger target ultimately when we think about this disease. And that leads us into some really nice data looking at MDM2 inhibitors. Mrinal Gounder at our institution has really been critical in trying to champion some of these drugs. This was the Daiichi drug that was recently picked up by Rain. The MDM2 inhibitors were actually limited in their clinical application because of an on-target effect in the platelets, so thrombocytopenia. But after looking at different iterations of the drug and its usage, an intermittent dosing schedule was developed in which patients could really tolerate the drug. And when patients with dedifferentiated liposarcoma actually received drug at that schedule, there were some really nice responses, so very encouraging data. And this drug is now moving forward into a phase 3 study versus trabectedin. So hopefully we will be able to get MDM2 inhibitors out to our patients. And finally, just in liposarcoma and transition into immunotherapy is going to be our understanding of what's happening with checkpoint inhibitors. We now know that liposarcomas can respond to checkpoint inhibitors, mostly in the sense of stability of disease, but other common sarcomas like UPS and myxofibrosarcomas can also have dramatic responses. This is just a trial of Nectar-214, a pegylated IL-2 with nivolumab, which we'll talk a little bit more in subsequent slides. This was a study run by Tonali Connolly and Sandra D'Angelo. But we now have emerging data sets in many different clinical trials understanding checkpoint inhibitors in sarcomas. Importantly, we are trying to use these studies to understand which patients should respond and why, and how to develop studies for these patients. Nice data off of the SARC-21 data set suggested that PD1 as baseline may be a predictor of response, although small numbers in UPS. There was some really beautiful genomic work looking at pre-treatment samples from the SARC-21 data set, identifying 5 different cohorts of tumors. Those that actually were hot, having a tertiary lymphoid structure, really seemed to have preferential responses, so potentially tumors primed for an immune response. This was a recent trial done by Kira Kelly looking at TVEC and pembrolizumab, a dramatic response of a myxofibrosarcoma that you can see on the screen. But what was important with this trial was the correlative work, looking at pre- and post-treatment tumor samples. First, on pre-treatment tumor samples, there were responses noted in tumors that didn't actually have TILs within the tumor, but TILs within the peripheral edge of the tumor, suggesting that there are some tumors that the immune system wants to recognize. It's important then to look at not only the tumor, but its surrounding tissue and trying to understand this. The other thing which was interesting is looking at some of the on-treatment tumor biopsies, where in some responders who were PD-L1 negative at baseline were actually converted to PD-L1 positive after treatment and actually had TILs enter into the tumors after treatment, again, suggesting that there can be some dynamic cold tumors that we can convert into hot ones over time. Moving then to some of the correlative work that Tony and Sandra have been doing that is just being published is giving us some interesting thoughts, again, on who should respond and why. Looking at the Nectar-214 study, it does not seem necessarily that TMB correlates with efficacy. Most sarcomas have low TMB, so we can see responses in tumors that do not have a high tumor mutational burden. Percent fractured genome does not correlate with progression-free survival. Clearly increased CD8 T cells and PD1 tumor cells at baseline and also on treatment correlate with efficacy. So very important to look at that on treatment sample. And when Sandra and Tony actually looked at the genomic landscape of tumors on this study, they were only able to come up with 3 groups, unlike the SARC-21 data set, potentially because, again, of the heterogeneity of the patients enrolled onto this study. There was an immune hot group, a cold group, and then an intermediate group. And again, the immune hot group really seemed to be the ones that responded. And when we looked at on-treatment biopsies, again, there were only 2 groups, so suggesting that there was a conversion of some of the patients in the intermediate group into a hot group. And it was those patients who on treatment had a hot type of immune genomic signature were also the ones that were responding, showing the dynamics of the diseases we treat. And again, preferentially trying to identify patients with cold tumors at baseline that can still respond to immunotherapy. And finally, for the last slides, there was also some other signaling pathways that seem to confer resistance. And one of them may be the hedgehog signaling pathway, as is also seen in diseases like melanoma. So it was really those tumors that had high CD8 T cells and low hedgehog signaling that actually had improved progression-free survival. So potentially something that can allow us to identify patients. So just in the last slide, Lyomyosarcoma, a lot of interest in PARP inhibition. About 20% of these tumors have DDR pathway analyses. Very nice data from Matt Ingram's group looking at Temodar and a PARP inhibitor, trying to understand response patterns, but a 32% response rate, which seems a little bit more than we would just see with Temodar alone. And then there's now also some immunological efforts of combining checkpoint inhibitors with PARP inhibitors, preferentially in LMSs that have DDR pathway abnormalities. So a lot of interest in here, but unfortunately leiomyosarcoma hasn't been a disease that we've had tremendous advances in. So I just wanted to have a few slides. And I will end my talk there. And thanks Javier and Nadia for having me here today. And so I appreciate it.
Thank you very much, Bill. Impressive update in soft tissue and GIST. So we are opening now the time for your questions, and you can launch the question in the chat, or maybe you can raise your hand and to make directly the question. So maybe starting by GIST, even when ripretinib has been in the randomized trial comparing ripretinib versus sunitinib, has been a negative study according to the press release, the recent press release. What do you think about the development of ripretinib? Should be stopped, this development? I mean, in second line, maybe the most frequent secondary mutations, maybe the driver in second line is most frequently the ATP binding pocket mutations or mutant patients. So in this specific context, sunitinib is as powerful as ripretinib in terms of IC50, according to the preclinical data. So maybe this is the reason why the phase 3 trial was named as INTRIGUE, because maybe it was not superior to sunitinib. But do you think is enough to stop the development, for instance, ripretinib in first line that could be tested alone or maybe in combination? Bill?
Yeah, I agree, Javier. I mean, I think, the same thing happened with Olaratumab. When you have positive studies, it opens up the field for development, right? When you have negative studies, it closes the field for development. Unfortunately, not so much because of the academic community, but what may be our pharmaceutical colleagues' commitment into a disease. And when you think about taking a drug like ripretinib, which is generally a well-tolerated drug, it does hit a broader mutational spectrum, even if it, maybe is not as broad or as efficacious as we assumed in that spectrum. I still think trying to move that up to an earlier line of therapy or using a combination therapy, in the right patient makes sense. What we understand with just in combination therapies, be it a MEK inhibitor or immunotherapy, you probably need that active TKI, right? So, if you can move it up to earlier settings where you will see that activity, I think that's critical. Whether or not we'll be able to do that now, I just don't know, right? But I think that's why we as a community need to understand why these trials fail, right? We can always say it's clearly, the drug, but there's going to be a lot of nuances. And also we have to believe that GIST is a much more heterogeneous disease, even in the second-line study, than we suspect. And are we accounting for that heterogeneity correctly when we study it?
Yeah, yes,
right.
it's
Maybe
true.
what you suggested of including circulating DNA within the trials to look which are the patients benefiting more from the therapies, that could help, because it's a pity that the negative trials, what you said, closes the door for further development. Okay, there are some questions on the chat, and also Michael Erickson and Olivier Mill have questions. So Michael.
Should I answer the questions in the chat?
In fact, yes. In fact, I think I was after Oliver, but I can start then. First, I would say that we need as many effective drugs as possible in GIST, since there are no cross resistance, and ripretinib has already shown to be very effective for some patients in later lines. So we'll see whether it can also get to place more upfront than in combination. That will the further development show. So absolutely, I think that is a good new drug for us. The other thing I wanted to comment is that I'm happy that you, Bill, took up the question about skepticism against placebo controls. We have done, there has been so many trials now with placebo controls. When Sutent was accepted, regorafenib trial, GRID trial, the RIGHT trial with Rich Challenge and so on, and all those placebo arms have been catastrophically bad. And even in those who had a crossover design, it's much worse, because some of the patients that could be crossed over will not be crossed over because it's too late. So by using placebo arms, we sacrifice some patients. That is obviously so. And since we know there is a heterogeneity in mutations, we know that even prolonging the earlier drug is better than having none. So it's much better, I think, with a new tyrosine kinase inhibitor to compare it with prolonging the earlier drug, actually, because it will be dramatic. And as we know also, and have some consensus, that no patients with advanced GIST should be out of any tyrosine kinase inhibition. Therefore, I think it's unethical to just go on with placebo arms. And the more sad thing, I think, is to cheat patients by the so-called best supportive care arm, which is nothing. And that is only, I think, to use the best supportive care argument, which is never defined, never compared with anything. It is just to cheat patients to think that both arms in this trial are good. And I think that is not in accordance ethically with the Helsinki declarations. So I'm glad that you took that question up.
Yeah, it was beautifully said. So I'll let your words sit, because I think it was beautifully said.
Olivier, do you want to make your question?
Yeah, sure. Sorry. So first, thank you, Bill, for the very nice presentation. And two short questions. The first one regarding GIST. In the, I think it was the Invectus study in the fourth-line setting for ripretinib, we had the opportunity to offer intra-patient dose escalation at the time of progression. And a recent publication suggested that it resulted in an additional median PFS of 3.7 months, something like that. And it was not allowed in the second-line trial against sunitinib. So my first question is, was the dose of ripretinib or the Skidle the right one in the INTRIGUE trial? And second question, in DD-FLIPO regarding CDK4 inhibitors and what you've shown on cell cycle arrest, do we have some, let's say, indications to suggest that these drugs could be used as maintenance treatment after first line?
Yeah, they're both great questions. I think the dosing question in ripretinib is going to be a big question, right? Because that is the dose that got the drug approved, right? And had the positive results of Invictus. So, you know, whether or not they should have used a higher dose, right? And maybe could have captured more of the resistant mutations, I think is critical. And we would always wonder, would those be 13, 14 or 17, 18? I suspect the former. I think the other thing along those lines is the dosing of sunitinib, which started off at a higher dose for a few cycles, right? Which is typically in the United States, we would use 37.5, but then led to, you know, intra-patient dose escalations potentially based on investigator comfort. So another variability that we have to look at, right? Because could have higher dose or allowed for better responses of sunitinib, or if it's used differently, but another confounder. But I agree with you, right? The design of the study will come into play in these negative results. It's just how much we can tease that out. The liposarcoma data has been very interesting for us. And I think we've been fortunate to work with Andy Koff, who was one of the initial discoverers of P21 and P27, and is really beginning to understand the pathway of geroconversion, now defining biochemically the events that are happening from a quiescent to prosenescent to senescent stage. And for one of the questions in the chat, you know, there are some biomarkers that are coming out of that. We do believe Mdm2 downregulation is necessary, but that would be a post-treatment biopsy. The other is there are other potential biomarkers like CDH18, which we may be able to pre-select patients who should respond. And also coming out of that, and I'll get to your question in a second, are potentially some reasons for resistance, like if you have upregulation of HRAS, suggesting that if you combine the drug with a MEK inhibitor, you can salvage a certain number of patients. So how to use it as maintenance is interesting, because I think the data shows that there's a good percentage of patient populations that can actually arrest with the drug, and then it's a wonderful maintenance drug in and of itself. There may be another patient population that if you allow for, you know, potentially more of an arrested state, right, would that actually allow for maintenance, understanding that these are cycling cells that you're trying to get into a quiescent stage, and how does chemotherapy affect that? So, you know, potentially some studies as to whether or not chemotherapy could actually align the cells at a certain stage in the cell cycle before you give the inhibitor. And I know there's been some combination studies looking for that, but these are great questions. I don't have the answer to the maintenance one, but you know, the right patients can really respond to these inhibitors. It would be figuring out how to select them, and then potentially enhancing the therapy in the patients who are not going to respond to single agent.
Reyes, please.
I will make it quick in the interest of time, right? I think both randomized trials in the GIST space that we've been discussing, I think they are casualties of the frequentist design. Now, I understand that we are bound by the frequentist designs because the regulatory bodies want them. But where I think we as a community may be failing or maybe not helping the designs of the trials enough is to make those assumptions as realistic as possible, right? I think what ends up happening is experimental arm does a little worse than we thought it was going to, control arm does better than what we thought it was going to, the two lines come together and p-value goes out the window. I think the Suten's PFS for its median PFS is a classic example. Avapritinib's median PFS in their own data set was 3.8 months. I can't possibly fathom how that was going to be superior to regorafenib in a randomized trial, right? So I think those of us who have influence, I think we have to insist to the company to not prematurely jump into a randomized phase 3 trial without having enough confidence and a good idea of what the expectation should be, right? So I think Bayesian designs would solve the problem, but that's not a reality. So won't keep preaching about that part. But I think us trying to help them predict the expectations appropriately would be very helpful.
Yeah, thank you. Thank you very much. I have a last question for Bill. I don't know if you are familiar with the randomized phase 3 trial comparing doxorubicin versus doxorubicin plus trabectedin and trabectedin in maintenance, the LMS-04 presented in ESMO meeting. But what is your comments around that? Do you think is enough for changing the paradigm, for changing the at least in Lyomyosarcoma, the standard treatment in first line? What is your thoughts?
Yeah, so I didn't include that because I didn't have access to all the data to really go through. But I agree. I remember, the doxil trabectedin data, which I thought was very interesting way back when. I thought the design flaw in that study was not the continuation of therapy after 6 cycles. But I do think of what I understand of the data, it's very intriguing, and potentially could move into a change in the treatment of that disease. But I haven't seen the full data sets to really look at, so I don't want to comment, but maybe put it back on you to see what you think and what are your thoughts on the data?
Thank you. So we are moving to the second speaker. Sorry?
Javier, there was another last question in the chat. Maybe we have time. So yeah, Pavel Soksuk asked if you think that Hedgehog inhibitors could fight against the resistance to immunotherapy.
Yeah, it's a great question and something I think we should look into. Again, smaller data sets, small number of patient populations, but there is some suggestion that there's a subset of sarcomas that have activity in hedgehog signaling, and that could confer resistance. So the next logical combination, would be some sort of hedgehog inhibitor, but maybe trying to identify those patients and then prospectively studying with the right hedgehog inhibitor is critical, and then understanding if we can actually convert some of the patients from cold to hot tumors, I think would really be important. But just early emerging data, but I thought very interesting.
Yeah, intriguing. Yeah, wind pathway also can be resistant for immunotherapy. So it's complex. The hedgehog is one of them, but I don't know if it's the only one.
It would be nice to look at some of the other data sets, right? Looking at the sunitinib nivolumab data set and seeing what you see, right? I mean, I think the problem is when we do studies, we're looking at 30, 40 patients, heterogeneous groups, and pulling out signatures of just a few patients. But can we add, N by bringing in other data sets? That may allow us to really understand the penetrance of some of these pathways that we're looking at.
Sure. So thank you very much, Bill. Brilliant as always. So we are moving to the Olivier Mill. He's a medical oncologist working in Gustave Roussy in Paris. And it's my pleasure to introduce him in the Selnet community. So he will be in charge of the update in uncommon sarcomas. So Olivier, is your time.
Thank you so much. Can you see my slides? Yeah, it's all right. Thank you. So first, I would like to thank the organizers for having me discussing with you updates in infrequent sarcoma subtypes. This is my disclosure slide. And I'm the bad guy on the bottom right of the slide, definitely. So in the interest of time, since we have something like 20 minutes, we'll be discussing 3 subtypes of interest: Nst Chondrosarcoma and Intimal Sarcoma. And I will give you a very short overview of ongoing clinical trials in my group. Starting with MPNST, we're talking about rare sarcoma, so we won't have the same numbers than in the previous presentation and definitive conclusions, but we're talking about a rare sarcoma which is not ultra rare because it's 4% of soft tissue sarcoma. We all know that half of them are associated with NF1, and it's the leading cause of mortality in NF1 patients. In terms of molecular pathology, we know that there's a loss of function of NF1 and some epigenetic abnormalities regarding PRC2 complex for conventional MPNST, and on the opposite, SMARCB1 loss in epithelioid MPNST. Regarding systemic treatments, to the best of my knowledge, there's only one randomized control trial in the neoadjuvant setting. This was a Gronchi trial showing that etoposide and ifosfamide was not better than epirubicin plus ifosfamide. There's no RCT in advanced disease. Doxo plus IFO lead to response rate and disease control rate displayed here, 24% and 62%. And we've had this year the publication of a small 12 patients Japanese phase 2 study with pazopanib, and figures are given here regarding response rate, disease control rate, and survival. So something quite disappointing. What about molecular targets? Well, first, BRAF. We know that a sizable proportion of sporadic MPNST have BRAF mutation that can be targeted by BRAF inhibitors. This is a small proportion of NF1 associated MPNSTs, but you have some very impressive case reports as the one published in JNCCN displayed here. And we also know that NF1 loss activates RAS, making rational MEK inhibition, but we also know that MEK inhibition is usually leading to resistance through HGF and MET signaling pathway. So MEK inhibitors alone might not be the answer. Second, the scoop this year was about Selinexer. So you know this is an inhibitor of exportin, XPO1. We have more than 200 proteins that are cargo proteins for XPO1, and you know the drug is approved for multiple myeloma, and we have a slightly positive phase 3 trial in Liposarcoma. And this year we had the publication by New York teams, and I think a team from Roma, I think it was Bruno Vincenzi, on MPNST, a retrospective series, 9 patients treated with Selinexer, and you see the numbers, 3 patients with partial responses. You can see the CT scans, some of them are quite significant, 4 with stable disease. So probably something we should be looking at further. Finally, just a word to remind that NTRK fusions are sometimes seen, perhaps not in MPNST, but NPNST-like tumors. So we're not sure because this is retrospective data from large series. We don't know a lot about pathology review, but MPNSTs are probably candidates according to recent publications in recommendations published in Annals, candidates for at least IHC screening and perhaps a little bit more in order to detect NTRK gene fusions. Immunotherapy in MPNST is probably, as far as single agents, PD1 and PD-L1 inhibitors concerned, not an excellent idea. You can see the proportion of TILs in MPNST on the upper figure. It's not really impressive. No tumors, even in small series, reported as MSI high. MPNST tumor microenvironment is enriched in macrophages and M2 macrophages, so perhaps a role for CSF1R inhibitors, and nothing fantastic with Pd1 inhibitors as single agents. So if we take a look at ongoing trials as registered in clinicaltrials.gov, you have the CSF1R inhibitor pexidartinib plus sirolimus phase 1-2 study. Ongoing, a phase 2 study at Princess Margaret, Toronto, with Selinexer, and the MET inhibitor, selumetinib plus sirolimus, once again, a phase 2 study. Second, we'll move to chondrosarcoma, and we will be talking mostly about high-grade conventional chondrosarcoma, so grade 2 and 3, and D-diff chondrosarcoma. We know that it's pretty different from mesenchymal chondrosarcoma, which are more chemosensitive. Regarding molecular alterations, we all know about IDH1 mutations, and there are some controversial data in the literature about IDH1 mutations and potential sensitivity to PARP inhibition, but we'll discuss this later. We know that there are alterations in RB pathway, TP53, and also sonic hedgehog. We've also mentioned mTOR and SARC pathways. There was a phase 2 study with dasatinib, as far as I remember. And we know that in D-diff chondrosarcoma, molecular alterations are basically the same that what we see in conventional grade 2 and 3 chondrosarcoma, in the conventional and the D-diff compounds of the tumor. So basically, this is from a molecular point of view, quite similar, quite the same disease. Regarding conventional chemo, we did a retrospective study 8 years ago within the French sarcoma group, showing that we had some pretty disappointing median PFS, slightly lower than 4 months with doxo plus cisplatin. We also did a phase 2, an open label phase 2 trial with the sonic hedgehog inhibitor, vismodegib, with a response rate of 0%. Even though some patients had stable disease, but we were not able to identify them through a correlative study with smoothen and patch assays especially. This trial was an IDH1 inhibitor. Bill is familiar with it. He's the first author of the paper. It was the AG120 compound, so first of its kind compound tested in chondrosarcoma. And as you can see, some patients had prolonged stable disease, but no objective partial response. We did a randomized phase 2 study within the French sarcoma group, comparing regorafenib to a placebo in 36 patients with chondrosarcoma. And despite the fact that the median PFS seemed to be higher in the regorafenib arm, the study was negative because the pre-specified median PFS threshold was set at 20 months. This is not 20, this is 19.4. So this is a negative study. And I would like to add my nickel regarding conventional chemo in those tumors. We know that these tumors express an efflux protein called P-glycoprotein, PGP, ABCB1, MDR1. There are 4 different names for the same biological entity. And doxorubicin is a substrate for PGP. So basically, most of those tumors are from scratch or rapidly become resistant to doxorubicin. But we know that gemcitabine is not a substrate for PGP, and it has limited, but let's say already assessed activity in those tumors. Second, we know that D-diff chondrosarcoma often, I will not give the numbers, we don't have a large cohort, mismatch repair deficiency features. And we know that oxaliplatin is active in those tumors, where cisplatin usually is not. And finally, we know that gemcitabine and oxaliplatin are synergistic. So we assessed retrospectively in the second line setting what GEMOX could provide against those tumors. And the results were presented. This is not an update. This is a 12 years old poster. I was a resident at this time. The very first cases of patients with Nst Chondrosarcoma treated with GEMOX. And as you can see, we had some, let's say, partial responses here on small lung mets, right there on bulky pleural mets. And finally, we've had more and more patients, and the manuscript is submitted in a small cohort, but with, let's say, some significant activity in patients pre-treated with doxo and cisplatin. So perhaps this is something we should think about. I cannot share the translational data because I don't have them at this time, but yet we're still working on it. Small series of patients, probably not something definitive, but we should probably take this into account. Remaining in the field of DNA repair, there was an interesting paper published earlier this year in JCO Precision Oncology with olaparib in IDH1 mutant tumors. Among them, 4 patients with chondrosarcoma, 2 of them with quite significant clinical benefit, one with a partial response for 14 months, the other one with a stable disease for 10 months. Of course, 2 of them had progressive disease as well. This is well, the reality of a small phase 2 trial, nested phase 2 trial in a bigger program with olaparib, but probably something we should explore once again regarding DNA repair. And finally, probably the most interesting finding regarding chondrosarcoma, a phase 2 study of a monoclonal antibody, which is an agonist for DR5. And you know that the phase 1 data were recently released and will be updated during the very same CTOS meeting, and quite impressive numbers, even though this is preliminary activity data from a phase 1 trial. Disease control in 14 out of 16 patients, 2 PRs, 12 stable disease, median PFS above 7 months, median overall survival not reached. Definitely something extremely promising from my point of view. And finally, regarding intimal sarcoma, another ultra-rare subtype, we all know that 80% of them arise in the pulmonary artery, but of course, we often have very early and sometimes synchronous metastasis, multi-site metastasis, lung, brain, and so on. There's an amplicon involving Mdm2 and CDK4. We know chromosome 12 and other amplifications, but we don't know if they represent credible targets for therapy. Systemic treatments outcomes are displayed here. Doxo being, I would not say the best, but I don't know if it says in English, the less worse option, with an overall response rate, which is not that bad, but it's retrospective data, 38%. I don't know if the numbers would be the same in a prospective trial. And very recent data from ESMO meeting, the first with an Mdm2 inhibitor, which was mentioned in the previous talk. It was a small study, 10 patients, but it's an ultra-rare sarcoma, 10 patients with advanced intimal sarcoma, pre-treated, 2 objective responses, disease control rate of 50%, well, let's say 5 patients out of 10, not that bad. And I would add an abstract, which was also presented at ESMO, 23 patients treated with oral metronomic cyclophosphamide, an affordable and not toxic drug. 23 patients, not that bad. And basically the numbers are the same regarding response rate, and you have some data on survival. Of course, it's retrospective, it's small numbers, but probably something, once again, we should explore in the context of an academic trial. And I will end my presentation with a few words on what we're doing within the French sarcoma group. Bill also mentioned the TLS and the paper in Nature from the American and French studies showing that 15 to 20% of soft tissue sarcoma harbor tertiary lymphoid structures, which might predict the efficacy of immune checkpoint inhibitors, and we have some interesting ongoing trials, especially the Congrats trial, which is a randomized phase 2 study, nivolumab versus nivolumab plus a LAG-3 inhibitor in TLS positive soft tissue sarcoma. And I'm not allowed to share some results, but I would say this is something interesting and we should follow first. And second, another trial, which is an open label phase 2 trial with Adesolazumab plus cobimetinib, which is a MEK inhibitor. And once again, probably something we should consider for patients with advanced MPNST. So I would like to summarize right there my feelings, my gut feelings. Selinexer in MPNST, probably something worth being explored. The DR5 agonist in chondrosarcoma is probably the scoop, the most fantastic scoop in chondrosarcoma for the past 60 years. And Mdm2 inhibitors in Intimal Sarcoma are probably a good target as well. And I would like to thank my colleagues in Gustavo C and you for your attention. And thank you so much.
Thank you, Olivier. Terrific talk. Very, very interesting. So we are opening now the options for questions from the audience. Just in the meanwhile, I have a very anecdotal experience with selumetinib in the context of MPNST without any success. I don't know if you have any responding patient to selumetinib or not.
We had a compassionate program for MEK inhibitors, so trametinib and so on. In my experience, in 8 patients, response rate is 0.
Yeah.
I'm waiting for the phase 2 results. But selumetinib alone, I don't know. The combination of both, perhaps if it's tolerable in terms of toxicity, but I don't have any experience with selumetinib alone or other MET HGF receptor inhibitors. I don't know if other people have.
Yeah,
we are now to share.
Yeah. Any other experience with selumetinib in the context of MPNST? Okay.
I think Michael has a question.
Okay. Michael.
Okay, I have a couple of questions against potential treatments in classical chondrosarcoma that you did not mention. The first one is Pd1 inhibitors, as has been reported, and we also have seen a couple of responses at our center. The second is Hedgehog inhibitors. There was a large, I think, transatlantic or even global trial about 10 years ago, I think, with a Hedgehog inhibitor, and that was closed early because of not enough response, but there were certainly some patients that responded. We had a couple of rather good responders in that trial. So I don't know whether Hedgehog inhibition may be explored further. What's your opinion?
Well, regarding Hedgehog inhibitors, I mentioned we had a phase 2, an open label phase 2 study with Vismodegib, which was the Roche compound. It was an open label phase 2 study, and some patients were included where they had non-strictly rapidly progressive disease. And you know, sometimes grade 1, 2, even metastatic chondrosarcoma have quite indolent disease. So measuring the impact of an investigational new drug in a non-progressive disease over the past 3 or 6 months is probably something difficult if you don't perform a randomized phase 2 trial or a randomized discontinuation phase 2 trial. So yes, there were some patients with prolonged stable disease, but we were not able to identify them through translational studies on patched and smoothened, which are the both subunits of sonic hedgehog. Regarding PD1 inhibition, I agree. I did not mention it, but there were some responses, I think, in SARC-28. It was a Nst Chondrosarcoma, as far as I remember. We have had a patient with a response in another trial. It was with pembrolizumab, and this patient had an MSI Nst Chondrosarcoma. So I don't know if the microsatellite instability status was investigated in other trials. I think it was in the SARC-28 or other trials, but we have some conflicting data in the literature about the percentage of Nst Chondrosarcoma which might be MSI high or not. But perhaps this is an explanation.
Okay. Okay. Yes, we have some experience with the differentiated chondrosarcoma and the combination of sunitinib plus nivolumab with some responses. And actually, there is a cohort with this in chondrosarcoma, just in the differentiated, because in conventional chondrosarcoma we haven't seen any sign of activity. But this cohort is now just with the differentiated chondrosarcoma, and I think is very, very attractive. Sandra Strauss is leading this cohort of Immunosarc-2 trial. And other questions from the audience?
Bill, one comment.
Okay, Bill.
Yeah, I thought that was a great presentation. And I wanted to ask what your thoughts are when we think about a disease like chondrosarcoma, conventional specifically, and we have newer drugs like the Inhibrx drug coming out. Do you think we'll have the right endpoints to really identify efficacy, right? You know, doesn't really respond by RECIST. Do we know progression onto trial, right? Do you have any thoughts on the best ways to think about these diseases from a regulatory design?
Well, that's an excellent question. Regarding the DR5 agonist, the responses were measured by RECIST 1.1. So they had real RECIST responses, 20%, I think, even if the numbers are small, but there were real dimensional tumor shrinkage. So that's the first point. Second, this is a rare disease. So Javier mentioned that they had a strata in a trial for nivolumab plus sunitinib. That's great, but the accrual of a trial might be the first hurdle. The second hurdle would probably be to pick the right design and the right endpoint, and I agree with you. Regarding with the design, once again, perhaps not with Nst Chondrosarcoma, but in some conventional grade 2 or grade 3 tumors, you don't have a linear progression of the disease. Some of them have some periods of time with stable disease, and it's quite difficult to handle an open label phase 2 trial. And I don't think that the regulatory bodies, even if you have a fantastically positive open label phase 2 trial, would agree to go for approval, even though we discussed that with EMA for ultra rare sarcomas such as ASPS. This is something that has to be discussed with the regulatory bodies. But I think in the context of a disease with potentially, let's say, not regressions, but periods of spontaneous stability, probably the best design is a randomized phase 2 discontinuation trial, not a randomized phase 2 trial against placebo, but discontinuation trial. This is probably the best from a methodological point of view, from what I've learned in medical school. I'm not an expert in the field of methodology, but what I remember from what I heard in medical school, probably a randomized discontinuation phase 2 trial is the most appropriate design. Conducting a phase 3 trial would be something quite difficult. And there's no standard treatment. I mean, there's historical treatment with Doxo, which is debated. It was published in JNCI 12 years ago, Doxo or not.
Yeah, thank you.
Mm-hmm. Olivier, regarding the Selinexer in the MPNST, I think the observations have been very interesting, even if they are scarce and only eight or nine patients.
9
right?
patients, I think, yeah.
Yeah, but this is a disease in which we don't have so many drugs. So I think I agree with you that it's worth to test it. And I think Javier was before going to comment that we have a phase 2 trial testing the combination, phase 1, phase 2 trial testing the combination of gemcitabine plus selinexor. You know. So this combination might be worth to test in a subset of MPNST patients.
Clearly. And well, these data are quite convincing because this is a hard to treat disease. So even though the numbers are small, 9 patients, retrospective design, and so on, this is probably worth being explored in a dedicated phase 2 trial. So there's a single agent trial on one hand and a combination trial on the other hand. I think this is something we should follow.
Yeah, yeah, we have tested in preclinical setting the synergistic action between gemcitabine plus selinexor, and we are ending now the phase 1 part of the trial, and is for Lyomyosarcoma enrolled patient. It seems very promising combination, and one of the cohorts in the expansion phase will be MPNST, obviously. Yeah, this is important. So I think we have to move to the next speaker. Thank you very much, Olivier. Terrific. And Nadia can introduce.
Thank you. Yeah, and so we are arriving to the third talk, and it's my pleasure to introduce Shreya Patel, medical oncologist from MD Anderson Cancer Center, who will update us on osteo and Ewing sarcoma. Shreya, it's your time. Thank you.
Thank you very much, Nadia and Javier, for this kind invitation. Let's see if I can get to the presentation mode. Are my slides showing up okay?
Yes.
Very good. All right, so I have to first at the outset confess that these are 2 areas, osteosarcoma and Ewing sarcoma, where much of the progress from a systemic therapeutic standpoint was made in the 70s and 80s, established cure rates of approximately 60 to 70%. And we have since then struggled to try to improve upon that. It's not been short of attempts. So unfortunately, I don't have results and exciting data to present to you, but I'm going to show you plenty of exciting attempts at trying to continue to expand the therapeutic spectrum for both these tumors. So starting off with osteosarcoma, I'm going to subset out my comment in 3 broad areas. We'll talk about targeted therapy. We'll talk about combinations primarily based off of the targeted treatments that have shown some signal of activity. And we'll close this part of the talk, the osteosarcoma topic, with some comments about immunotherapy. And I'm going to prepare you that there is no data, but at least there are trials or attempts that are going on. So I think this audience is very much aware of the VEGF inhibition, going back to the Uramos-1 trial. The poor man's anti-angiogenic agent available at that time was interferon, and clearly the concept was, can you improve upon the outcome of the good responding subset, adding interferon to the MAP chemotherapy backbone, right? So the concept of adding an anti-angiogenic agent has been around for quite some time. We just have newer and different agents that are now available. And the newer generation molecules do seem to be showing some level of activity. So here is Lara Davis's publication of the SARC trial testing regorafenib against placebo in patients with metastatic osteosarcoma that have failed prior therapy. And as you can see, there is some improvement in the progression-free survival, not so much in the overall survival. The French group obviously has published on the Carboxantineb trials, both in osteosarcoma and Ewing sarcoma subset. And as you can see, there is some level of activity in terms of RECIST responses, fair bit of stabilization, suggesting that this class of compounds may well have a role in prolonging progression-free survival rather than shrinking gross disease. And to expand that spectrum, here is a summary slide of several different anti-angiogenic agents or VEGF inhibitors that have been tested in this group. And it appears that Carboxantineb seems to be the favorite, simply based on the most impressive progression-free survival amongst these class of drugs. So further attempts at trying to develop Carboxantineb have been taken on. The Children's Oncology Group is going to start off with a feasibility phase 1 dose finding study trying to combine Carboxantineb in the face of the MAP methotrexate, doxorubicin, cisplatin backbone of chemotherapy. Once they get to the appropriate dose and schedule, they have a very ambitious plan of running a randomized trial. I believe it's all going to be over 600 patients, if I remember the numbers correctly. But the idea here would be to randomize these patients to either MAP alone or MAP plus Carboxantineb, and following them over a period of time for progression-free survival. Clearly, the hope is that this might help us achieve that prolongation of progression-free survival, but the trial will still need to be finalized, start enrolling, and the results are several years away. Our group, one of my younger colleagues, Andy Livingston, has taken on the task of combining Carboxantineb with Adesolazumab, another Pd1 inhibitor. As all of you know, and we'll come back to this a little bit later in the talk, single agent PD1, PDL1 inhibitors have not shown any impressive activity in either osteosarcoma or Ewing sarcoma. And so the efforts are directed at trying to combine them with other agents, or as you will see later on in the presentation, trying to circumvent resistance or induce some sensitization. There is some additional translational data that shows that there are increased Carbo targets in the immune infiltrated osteosarcomas, right? So the few that may show some immune infiltrates, there might be some sensitivity to Carboxantineb. So we're planning a 40-patient Bayesian design trial looking for a median PFS. The trial is just about to get started, so absolutely there is no result. There are no results for me to share with you, but at least another attempt at trying to take the VEGF inhibition story a step beyond. Along the same lines, Lara Davis, on behalf of SARC, is going to start SARC 38, again, a single-arm, two-stage trial, trying to combine regorafenib, capitalizing on the regorafenib versus placebo data that you just saw, combining it with nivolumab to see if the combination does indeed improve activity, efficacy, and outcomes. From a new target standpoint, I think, as everyone in this audience knows, checkpoints, cell cycle checkpoints are very critical in a variety of different tumor types. Specifically, when we look at the G2M checkpoint that is regulated by the Wee1 kinase through a CDK1 mechanism. And what ends up happening is that inhibition of the Wee1 kinase would then lead to CDK1 forcing the cells into entering mitosis. So this is sort of like if we use the analogy of acute myelogenous leukemia, it's trying to drive those cells into replication mode with a growth factor and then hitting them with chemotherapy to kind of get a bigger bang for our buck, if you will. There is some evidence based on cell viability assays that there is some single agent activity of these Wee1 inhibitors in a variety of different tumor types, including osteosarcoma and in some Ewing sarcoma cell lines. There is synergy with gemcitabine, one of the nucleoside analogs, and as you can see, the combination of gemcitabine and the Wee1 inhibitor CM31 does indeed show some clinical benefit or some laboratory benefit in this cell line data. So this is the basis for COG, again, embarking on a phase 1/2 dose escalation, dose expansion study. Initially, obviously, they will need to find the recommended phase 2 dose for the ZN3C3 combination with gemcitabine. But once that is achieved, I think the plan is to sort of expand it to a phase 2 study, primarily looking at event-free survival at 18 weeks, one of the COG endpoints that we're trying to replicate and improve upon. From a monoclonal antibody standpoint, I think this technology has continued to advance. Again, as all of you are aware, we've gone from hybridomas to chimeric antibodies to humanized antibodies to antibody drug conjugates. And I think the latest attempts seem to be concentrating on what is called conditionally active biologics and combining them with an antibody drug conjugate. And more specifically, I think targets like AXL, for example, that seem to be overexpressed again in a variety of different tumor types, not necessarily specific to the mesenchymal tumors that we are used to treating. And within the sarcoma subset, as you can see down here, several of the bone and soft tissue sarcoma subsets have been shown to have overexpression of AXL. So the idea here is to have an anti-AXL humanized antibody that's specific to the AXL in the tumor microenvironment. To that antibody is tagged an anti-tubulin agent, a Adesolazumab 10 analog, if you will, an anti-tubulin agent. And the whole idea would be for that ADC to get that molecule to the tumor cell, the linker gets cleaved, and the payload is delivered, if you will, in terms of the cytotoxic therapy. So theoretically, this sounds interesting. There is proof of principle of this in a variety of different other solid tumors and hematologic malignancies. So BioAtla has a compound BA3011, and they're planning a single arm or a monotherapy arm in bone and soft tissue sarcomas, with an eventual plan to try to combine it with nivolumab to see if there will be synergy versus additivity. That's transitioning us into the immunotherapy arena, if you will. And again, you saw this slide earlier. This is SARC-28. And again, activity of single agent pembrolizumab or nivolumab has not been very impressive, as you can see in the bone sarcoma subset, both osteosarcoma and Ewing sarcomas. And so the attempts that are ongoing are trying to circumvent resistance. Is it possible that CD73 is protective and an anti-CD73 antibody, oleclumab, added to this anti-PD-L1 molecule, durvalumab, will make a difference? You heard about the Nectar-214 story earlier from Bill. And again, the bone tumor patients were eligible for that trial to try to see if that strategy works. CD47 is a transmembrane protein, again, part of the immunoglobulin superfamily. And from a functional standpoint, not to get too complicated, this is supposed to protect the tumor cells from the cytotoxic effect of the macrophages or the immune cells. And so anti-CD47 antibodies are starting to come along. And again, they're being tested in a broad array of different malignancies, some of our mesenchymal tumors, including osteosarcomas being one of them. Our pediatric oncologists in the audience will recognize the GD2 target. This ganglioside antibody has been around for a long time. As all of you know, there is a approved drug for neuroblastomas. And this anti-GD2 target is being revamped, if you will, with even attempts at trying to make modified CAR T cells. And then the CAR T cell manufacturing against several different antigens is also being pursued, and a bunch of them are listed up here. Of interest may be HER2, and for those of us who've been around for a while, you'll recall that HER2 expression on osteosarcoma cells has been a known thing for a long time. As trastuzumab and some of the other HER2 antibodies were coming along, the phase 2 trials did not really show any activity of the monoclonal antibody in that setting. But the idea then would be, can the expression of that antigen on the surface of the cells allow us to sort of create CAR T approaches specifically against HER2, if you will. And then finally, there are attempts, again, broad spectrum attempts, primarily for advanced in cervical carcinoma, for example, of autologous tumor infiltrating lymphocytes, right? So you take the tumor out, they're genetically engineered, reinfused back into the patient to try to see if there is going to be any activity. So a lot of different attempts that may sound like we may be throwing spaghetti at the wall to see what will stick, but at least there is some scientific basis for it. And I think this will keep this area exciting enough for us to continue to develop further and see if one or more of these areas show enough signal of activity to then come back to the discussion that we were having earlier. Well, what would be the best path forward to help make the drug and the combination rather than break it with a poor study design? So moving on to the Ewing sarcoma subset, I think I will break up my comments here again as they relate to trials looking at targeting kinases and receptors. The most interesting area here in the Ewing's family of tumors is targeting the fusion. As you know, the EWS fusion with one of the ETS proteins is oncogenic, and the Ewing cells seem to be highly dependent on that fusion transcript for oncogenesis. And previous attempts at trying to attack this fusion transcript have not been successful, but we now finally have a couple of drugs that at least address the enzymes that are critical for that fusion transcript to go downstream and induce oncogenesis. And from an immunotherapeutic standpoint, in addition to what we've sort of talked about for the osteosarcoma type, there is something unique to the Ewing's population that has been studied, and there are plans to combine it with chemotherapy, and we'll talk a little bit about this. So a summary slide of what all of you very likely know. This has been out in the published world, VEGF receptor inhibition in Ewing sarcoma. Again, you see the same culprits, Carboxantineb, Regorafenib, and Lotinib, primarily available in China. But as you can see that there is some improvement in the progression-free survival, suggesting the cytostatic effect, if you will, if I can use that old term. Here is some proof of principle activity. This is Regorafenib in combination with vincristine and irinotecan from our French colleagues, and Lotinib with the same combination of vincristine and irinotecan by our Chinese colleagues. And you see that on the waterfall plot, these are rhabdo and Ewing's patients, but you see that there is at least proof of principle activity to hopefully be able to develop further. Problem here arises in selecting the chemotherapy partners, right? Here is the UCSF attempt at trying to use the standard irinotecan and temozolomide combination that then makes it intolerable based on toxicities, primarily myelosuppression and the irinotecan-related toxicities. PARP inhibition is a story that has gone on for a very long time. SARC had an initiative that started back, I want to say, almost back in 2011, where there was emerging data that PARP inhibition, especially in combination with chemotherapy, like temozolomide, for example, could be additive or synergistic in some ways and may have a role to play, right? I think in the process of the investigation, I think a few things became quite obvious, that not all PARP inhibitors are created equal. So you couldn't just take the olaparib data and kind of try to extrapolate it to veliparib, niraparib, or et cetera, et cetera. So I think there were some nuances of individual PARP inhibitions. And then the biggest issue, as we encountered in the SARC-25 trial that Sandra Strauss and Rashmi Shug ran for the group, is that when you try to combine these drugs, you are unable to give the full doses of both agents, right? You couldn't give the PARP inhibitor at the full dose, most certainly not with temozolomide. And even with the irinotecan backbone, I think it was difficult to deliver the drug. So I think while there is in vitro proof of principle activity, the problem in the human model has been the overlapping and cumulative toxicities that have hampered the further development of this particular combination. CDK4/6 is an evolving story. I think there is cell line data that shows that there is CDK4 dependency in Ewing sarcoma cell lines. You then see that when you combine that with a PARP inhibitor, there is additive effect, or at least there is some additive effect in the sense that when you use all three drugs, you have a combination of temozolomide and irinotecan in combination with a PARP inhibitor that starts to show some decrease in the cell burden, if you will. So companies that make these drugs, PARP inhibitors, if you will, or CDK4/6 inhibitors, are starting to think about trials looking at palbo plus temarino or Cytopo, abema plus temarino. And I think while this is very premature at this stage, I think one, it's important to know that this is being developed, and two, I think time will tell as to how that story unfolds. The IGF-1 receptor antibody story, again, has been a long ongoing story. We tested the Roche molecule R1507 in SARC11. Other molecules like fejitumumab and ganitumab have also been tested. And I think the bottom line is that while there was proof of principle activity of these IGF-1R antibodies, the response rates were relatively low. The response durations were very short, meaning there was quick development of resistance. So I think the idea was that could this be, again, just added to the chemotherapy backbone, and will that make a difference in the event-free survival? And unfortunately, a large COG study, AWS 1221, that took patients with Ewing sarcoma and randomized them to the induction chemotherapy regimen alone versus chemo plus ganitumab in the initial induction setting and in the post-local therapy setting. Unfortunately, as you can see, the Kaplan-Meier curves are virtually superimposable with no significant difference. So I think the IGF-1R antibody story is still continuing to linger on. Joe Ludwig, one of my colleagues, has an interest in this area and kind of compiled the 5 clinical trial data that was available out there. And the sense seems to be that the combination of an IGF-1R antibody with an mTOR inhibitor may well improve the progression-free survival a little bit, but doesn't still make an impact in terms of the overall survival. How this combination of the two drugs can be incorporated into the current therapeutic armamentarium is still a challenge and remains to be proven. As I mentioned earlier, I think the fusion transcript that drives the oncogenesis in these patients with Ewing sarcoma has been an area of interest in terms of targeting. There's a Tocalis drug, TK216, that inhibits the RNA helicase. A lot of the Steve Lesnick's work on the lysine-specific demethylase 1 is also starting to take some shape, although it is a bit premature. And then I'm going to show you some of Patrick Grohar's data resurrecting some of our old friends, if you will, trabectedin, lurbinectedin, not necessarily as a cytotoxic as we know it, but more as a inhibitor of the fusion transcript and its downstream activities. So this is the Tocalis data. Normally what ends up happening is that to the EWS1 component, the RNA helicase needs to bind for it to continue the downstream pathways for tumor cells to continue to grow. If the TK216 drug binds to this, to the EWS FLI1 component, displaces the RNA helicase, then all of a sudden the tumor cells are then programmed to die, right? Theoretically sounds very good. I think, again, there is some proof of principle activity, but certainly nothing worth writing home about. I think it took us a while to try to get to the right dose and schedule. But at the appropriate dose and schedule, you do see that there can be some anecdotal responses. The problem is that the durability of the responses seems to be short, but that may also have a lot to do with how well can we work out the chemotherapy partners with it, right? So this is an evolving story, certainly not ready for prime time yet, but hopefully holds some promise for the future. The Lsd1 inhibitors, again, there are a variety of those out there. I think the utility of Lsd1 inhibitors also is very broad spectrum in a variety of other solid tumors, including some non-malignant diseases like multiple sclerosis. I think the Celerius compound, Seteldemistat, SP2577, is the one that is in human trials in the phase 1 setting. I think as you can see the in vitro data, it does show some slowing down of those tumor cells and arresting the growth pattern. Whether that translates into tangible benefits in terms of responses or progression-free survival improvement still remains to be seen. Patrick Grohar has had a great deal of interest in this particular area. And I think he's looked at trabectedin and lurbinectedin that will show up on the next slide as inhibitors of the EWS-FLI1, and there's some schedule dependence. That is, data suggests that it really has to be given as a 1-hour infusion. Here is the lurbinectedin data that sort of supports the same kind of notion. And then SARC-37 that is about ready to start enrolling is going to combine trabectedin as a 1-hour infusion with irinotecan to try to see if what shows up in the lab, and I showed you on the previous slides, and Patrick has plenty more data on that, will it translate into clinical benefit in human beings? And a final comment about, from an immunotherapeutic standpoint, autologous tumor vaccine is an area that has been tested. The company that makes this particular compound called Vigil, and here is the latest publication from or this is actually back from 2016, but there is an updated information on this, where what they've done is they take patients' Ewing's tumor out, so autologous tumor that's then taken out and transfected with a GM-CSF DNA plasmid to turn it into an autologous tumor vaccine administered to the patient subcutaneously. And I think we can debate the scientific strength of this data set, but what they do have is a cohort of 16 patients that they treated with the vaccine. They're comparing it to a contemporary cohort of 14 patients who did not get the vaccine. And the claim is that there is some prolongation of survival in the group that got the autologous tumor vaccine. And the claim also is that there is no toxicity, right? So certainly sounds very interesting. I think they are planning to combine it with the Temarino salvage chemotherapy model. And we'll stay tuned as to how this eventually pans out. So with that, I think I'm going to stop and open it up for discussions. It's quite likely that there may be a few different other approaches and trials going on in your neck of the woods that were not on my list, but I hope you would bring that up in the discussion phase. And again, I thank you for your attention and look forward to the discussion.
Thank you very much, Sorayas. Fantastic review, as usual. We have a first question from the audience. Celso Melo from Camargo Hospital in Sao Paulo said, Dr. Patel, do you see any promising partner combination for Ewing inhibitor for patients with p53 mutation, target agents or cytotoxic agents?
I don't think we know the answer to that question, right, Celso? That's a good question. I think there's clearly theoretical rationale for it, but at least I'm not aware of any data or any attempts at trying to develop that further. If anybody else in the audience is aware, I would love to hear it.
I think there was interest, Shreyas, in the trial design, maybe to include some sarcoma subtypes with p53 mutations, because I do think the rationale, like you point out, is really important. I think because they focused it more on osteo and pediatric indication, I don't know if it's moving in that direction, but I would agree. I mean, it's a great idea.
Okay, thank you. Bill, do you have any question? Because your hand is raised, or is Olivia?
Yeah.
Okay.
Yeah, thank you. Thank you for the excellent presentation. I have one comment and two questions. First comment, I fully agree about Carboxantineb. I think this is really a fantastic drug for bone sarcoma. I have two patients with metastatic Ewing sarcoma in the second-line setting, treating with Carboxantineb for 4 years.
Wow.
Histologically proven metastatic Ewing, bone and lung, 4 years.
Wow.
I've never seen that with any other drug. So that was the first point. Now, two questions shortly. One, you mentioned among CAR T-cell targets, CAR T-cells directed against HER2. And we know that some osteosarcoma overexpress HER2, even though it's not a driver. Do you have any idea of potential ADCs which could target HER2? Because even though HER2 is not a driver, it could be a target for an ADC, especially if you have a bystander effect. We've seen that in other malignancies with trastuzumab deruxtecan, for instance. I don't know if you're aware of ongoing or planned clinical trials with such approaches.
So I did not specifically run into it as it relates to sarcomas, but you're absolutely correct that I think HER2 being a promiscuous enough target in a variety of different tumors, the entire ADC, the conditionally active biologics antibody drug conjugate area is just casting a very broad net. It almost like history keeps repeating itself, as we know it always does, right? I think when the Pd1, Pd1 inhibitors were coming along, we were just throwing it at everything and everyone to see where it will stick. And my sense is that as technology is improving, the entire ADC area is doing the same thing. If there is some evidence of a target, let's just throw at it and see what happens. So I think there are attempts, but I'm not aware of anything specific in the sarcoma field.
And final question. I'm not really comfortable with clinical trials assessing anti-VEGFR agents concomitantly with chemo. You mentioned the trial from the Children Oncology Group with Carboxantineb plus MAP. We have a Me2 trial in Europe with lenvatinib plus IE, ifosfamide and etoposide. In my experience in other solid tumors, concomitant multikinase inhibitors plus chemo was always a failure. And most importantly, oral anti-angiogenic agents in localized tumors was always a failure as well. So there was a recent phase 1 trial of lenvatinib plus IE published in Lancet Oncology. They say it's feasible, but it's not because it's feasible that it's a good idea. And once again, it's feasible in children. And I think if you're moving to adults, once again, in my experience, single agent cabo or single agent lenvatinib, relative dose intensity is a catastrophe. So in combination with chemotherapy, I don't know what we expect. I don't know what's your feeling about those drugs, perhaps in maintenance rather than partners for combinations or short-term sequential treatment. I don't know.
I absolutely agree. I think the tolerance gets maximized when you use either component alone. You try to put the two together, and I think you end up with that PARP inhibitor and chemotherapy kind of a
Same,
story.
sorry.
And so that's why I think with some hesitation, and maybe I was going too fast, and I didn't show extra slides, but in their initial dose finding study, it's not just a dose finding study, it's a dose and schedule finding study, to be honest. And I think we've gone through this. Bill showed the meladimetan experience, right? That we had to keep struggling with a variety of different doses and schedules, on again, off again. So I think it will be interesting to see how that initial early exercise of coming to a recommended phase 2 dose works out. And in that context, then I'm sure that the master plan of that large randomized phase 3 study may well have to be revisited, right? So I share your concerns, and I do share the skepticism that I'm not so sure that it's all just going to be tolerable and fine. But then the flip side is, until we test it and until we go through the experiment, we're just not going to know, right? So I think I have to applaud them for the attempt and for their effort. But you are correct that I think it's not a signed, sealed, done, delivered, guaranteed thing.
Shreya's a great presentation. Quick question about osteosarcoma. You know, this was a disease 5 years ago. A priori, I would have said, we're going to see responses in immunotherapy. You know, it's a shattered genome, genomically complex, but yet across the board, we see nothing. You know, why is that? And do you think the approach our community's taken, you know, when we look at, say, you know, let's have, you know, a small cohort of 5, 10 patients or 20 patients and all these different approaches trying to put agents together. Is this the right approach? As you said, are we going to come up with signals to say, how do we move this forward correctly? Or you know, should there be some more basic approach that's leading us in the right direction?
So I think, Bill, you're absolutely correct. But I do think that people have tried to dig in deeper, right? There are people like Rich Gorlick, for example, and so many other folks around the world who have studied. I think Fran Hornicek was on the call, if I'm not mistaken. And so several people have dedicated lab efforts to try to figure that out. It's just that the enigma continues on, right? We haven't stumbled onto it. And so, you know, from a hopeful standpoint, you keep digging, and maybe you keep digging, digging, and maybe the treasure shows up. But until then, I think as much as we may see the flaws in this approach of, like I said earlier, throwing spaghetti at the wall, see what sticks kind of thing, I don't know of a better way of trying to do it, right? Not making an attempt is not an option. These are the only attempts that are practical and doable. Now, it would be wonderful if, you know, we had this KIT mutated tumor and the KIT pathway is activated and you have KIT inhibitors and you change the lifespan of that patient with GIST. It's a wonderful paradigm, but as we all know, we've been looking for that paradigm to replicate itself for quite some time. And until the NTRK story came up, we didn't have anything to show for it, right?
Yeah.
So I don't know the right answer to the question, but I mean, if anybody else in our esteemed audience knows, I mean, this is an area that we all need to just brainstorm together and figure out a way forward.
I agree completely, right? And then you know, it's what we have to do, but I also wonder, like, what will be the signal when all of a sudden, you know, you see one response in a trial, 3 responses, and then can we quickly pivot and organize the community against, you know, with that, it's an interesting concept, but
Oh, you're absolutely right. Difficult.
Nadia? I have a comment, and it's related with Bill's question. So immunotherapy in osteosarcoma is a long story, from Collis toxin, and then mifamurtide also had an effect, and even anti-angiogenics could have an immunomodulatory effect, mainly modulating macrophages. So I don't know, maybe we are focusing on lymphocytes or on the lymphocyte immune system, and we have to focus more on innate immune system. I don't know, maybe we are looking at the wrong place.
Yes,
And
maybe, sorry.
No, go ahead, please, Javier.
Thank you. No, just our experience in Immunosarc 1, the bone tumors was led by Richard Lee team, is that no very important signal of activity was seen in this cohort. But we don't resist to abandon the probability of immunomodulation in osteosarcoma, and we are opening a new cohort exploring the immunogenic death in the upfront therapy for metastatic patients, integrating in the MAP scheme the anti-PD1, because doxorubicin and cisplatin are important drugs for immunogenic death. So we want to explore that, but maybe Nadia, as Nadia said, the axis PD1, PD-L1 is not the most important axis in osteosarcoma. Who knows? But we don't resist to test that.
Yeah.
Sorry.
And the enigma is there, right? I mean, we don't quite understand, why do those checkpoint inhibitors work in alveolar soft part sarcoma? It's the quietest tumor ever. There's not much of an infiltrate yet. That's where we see the highest probability of response. So I think there's plenty that we don't understand. And I mean, hopefully with continued efforts, there might be hypotheses that come along that will enlighten us.
Yeah. Okay. Any other question from the audience? Okay, otherwise we will finish here. It has been very impressive meeting. I enjoy a lot. Thank you very much, every one of you. Every lecture was a high-level lecture. So these presentations will be available in the Selnet website in upcoming days. And stay connected with Selnet events. So hopefully in in a short time we will meet inside, and the next consortium meeting will be held in March next year in Peru, in Lima. So hopefully we will meet there physically, not virtually. So thank you very much for your time. Thank you every attendees of this meeting. The peak of attendees has been 84 connections, maybe more people. Thank you very much for that. And we are in touch. Take care. And Nadia.
And please switch on your cameras for the traditional photo, because we are making already an album of all Selnet meetings.
Oh, yes.
Okay, one more, smile. Okay, I think I have you all. Perfect.
Okay.
Thank you.
Thank you very much.
So much.
Take care.
Bye-bye.
See you. Bye-bye.